because this is internal, it's kind of a training for everybody. So I welcome feedback. This is not a, this is a living document, living presentation basically. So a lot of you are familiar with presenting a lot and content and how to present. So I welcome feedback. If things make sense, if they don't make sense, please let me know. After a while you don't see things, so look at it over and over and over, and it's just like, yeah, it's great, it looks fine. So I'm always looking for feedback on this. And my intent today as an agenda is intro. So this is a slide deck that I use. I've done a few in-services. I've done Broward House and I've done SunServe. So I'm looking to do this at different agencies. So the deck is really not for this setting, but again, it's a set deck, and so I always try to go by the same slide. So basically what I do is have an intro, and then the content is understanding PrEP. What is PrEP? PrEP research and why we need research. How PrEP is taken and who's a candidate, which is really important. So the kind of red flags, the things you listen for when a client comes in, who might be a good candidate for this. Access to PrEP, so there's some misunderstanding or information out there about is it covered by insurance and how much does it cost and how do we get it. So I'm going to cover some of that. And then talking to clients about PrEP. So how do you have that quick 30-second conversation with somebody and not go into an hour-long presentation on PrEP, because nobody wants to do that, you don't have time. And I do want to thank Jim Pickett as well as Dr. Dawn Smith from the CDC, who was here presenting at DOH recently. She actually did a continuing education on PrEP, so I got to talk to her directly. So introductions, who am I? I'm the PrEP specialist, so this is basically just what I do, outreach, education, that type of thing. This is my job description, which I won't go through here. One thing we're not doing is I don't push PrEP. Shouldn't be in the water. It's not like fluoride. It's for certain people and not for certain people. But I do push, I'm an advocate for education. And as a pharmacist, I want people to understand their health and make proper choices. And they do that through education and understanding. PrEP is sometimes posed as a debate, either condoms or PrEP. I don't do that. The paradigm of seatbelts and airbags is always in my mind. It's layers of protection, and if you forget one or you choose one at one time and choose another at another time, that's great. So it's all about adding in layers of protection, and we do that all the time, and I'll go through some of that. More tools in our toolkit. The second to last one, if you keep doing what you've been doing, you keep getting what you've been getting. We have about 50,000 infections a year in this country for the past 10 years or so. We need to do something. Something needs to change. I'm not saying PrEP is the way to change it, but it is probably the most advanced biomedical intervention we've had in a long time. And then, the question is, we do research for a reason. It's not because we're going to find the perfect solution. We're going to find things along the way that make sense. So we do research for a reason. So what is PrEP? So you've probably heard a lot of these things said recently. We don't know the side effects, it's too expensive, insurance won't cover it, it hasn't been studied enough, this type of stuff that's out there. This is the same type of argument that was made, these same arguments against the birth control pill over 50 years ago. It was exactly the same. It was a biomedical intervention. There's a lot of controversy about it. There's a lot of personal opinions about it because it has to deal with sex and sexuality. So a lot of stuff gets mixed in there. This is not a new paradigm. We have prophylaxis that we do all the time. So it's important to keep that context, that this is not a new and novel type of thing that we've never seen before. We do this a lot. So what is prophylaxis? It's a measure you take before something happens to either maintain health or to avoid a situation you don't want. So birth control, we have condoms, we have the rhythm method, we have the pill, we have a number of different ways to prevent conception. Malaria, I was in Kenya for a while. I took anti-malaria meds. Why? Because the environment I was in was at high risk for malaria. When I left, I stopped taking it. It's not because I had malaria, it's because I was in a risky situation and I needed to protect myself. I also use bug spray. If you go to the dentist and you have an implant, you'll often take antibiotics before you have a procedure because the bacteria can get into your blood and then can sit on your implants. And so this is prophylaxis also. toothpaste, vitamins, supplements, we probably all take some of these. Why? To prevent stuff. Not because we have rickets and scurvy, but because we want to prevent something from happening. The gym and eating right, we're trying to prevent something, heart disease, whatever it is. And seatbelts and airbags, and that's the big one. There are two big analogies that are used with PrEP, seatbelts and airbags. So use it along with your other protections, because other things prevent other things. And also birth control pills. It's an empowerment for somebody to take hold of their own health and not depend on somebody else telling them that they don't have to worry because they're either undetectable or they're negative or something else. It's a way for people to be empowered with their own health. So for HIV, there are a number of prophylactic measures. So I want to throw it out, just yell out, how do we prevent HIV? I mean, we do this every day, just some ways that we prevent HIV. Condoms, abstinence,
Monogamy.
yes. So we have abstinence, monogamy, condoms, male and female, safer sex, things like more oral sex or frottage, grinding, that type of thing. Serosorting, seropositioning, seroadoption, I think is a general term used for that now, is negative with negative, positive with positive, or being receptive or insertive, depending on what the status is. Does that work? It might. I think the data is questionable at this point. There's also treatment as prevention, which is extremely important. We have the HPTN 052 study, which was done on heterosexuals, that showed greater than 90%, something like 96% protection if somebody is truly undetectable. They are basically non-infectious, which is huge, which is why we want people to stay on therapy and to be suppressed. We also have a new study, the partner study, which is done in heterosexuals as well as gays. It's not done yet. They have about, to date, I think the number is 30,000 different sexual encounters that they've analyzed. And they found the same effect as the first study, which is if you're suppressed, you're basically non-infectious. So that is actually in both the MSM group, the gay group, as well as heterosexuals. So this truly is a preventative method. But it does rely on somebody else to, it relies on you trusting somebody else to be taking care of themselves and not empowered on your own to be able to say, yes, I'm protecting myself. And then we have PrEP, which is Truvada. They're not the same. PrEP is a paradigm of healthcare. It involves things like HIV counseling and the use of condoms, seeing doctors. The pharmaceutical component is Truvada, which we all know probably. It's a drug that it's two-drug combination. It's one pill. It's an antiretroviral. And it's one pill taken once a day, combined two antiretrovirals, and basically prevents HIV from replicating. The body can clear HIV from its system, which basically these drugs enable the body to do. So the infection can't take place and the virus particles are cleared from the body. So it's not like you become a carrier and it's in your body. It is actually cleared from the body. And those are the two drugs. So again, birth control prevents what? Pregnancy. Malaria meds prevent malaria. Toothpaste prevents cavities. PrEP prevents HIV. If you want to protect against other things, you need other protections. So a lot of times STDs are thrown in there. Herpes, hepatitis, what about this, what about that? I talk about HIV. We have to start checking the list off of things that we need to start preventing. Yes, the STDs are rampant in this area also, but we can't keep saying, well, we have to do something about everything or we're not going to do anything. So we're starting. PrEP gives us another in for HIV prevention. So why stay negative? This question came up at the town hall. Actually, somebody submitted a question with, if I have to take a pill every day and I have to go through insurance and see a doctor every 3 to 6 months, why bother staying negative? If I can get my meds for free if I'm positive through ADAP or Ryan White, and I see my doctor anyhow, and I can have a full, healthy life. There is research out there, but the very nature of the question makes me want to include a slide like this and to really go back to there is a reason to avoid HIV. It is a manageable disease now. It's chronic, like diabetes or high blood pressure, and they're totally manageable. But there is some research that shows whether it's HIV itself or the drugs you have to be on indefinitely, that there are some problems that come up. There's premature cancers, there's neurological problems, there are other organ problems that are associated with having HIV. Can you have it chronically and lead a healthy life? Absolutely. I'm on an aspirin every day because I'm at risk for heart disease. We all live with these chronic conditions, so it's just important, I think, to point out that there are some real medical implications to being positive. There's also cost, there's the dependency on insurance, so if you lose a job or you have to get new insurance now, there's a certain dependence on those things. There's also interactions. You have to be on a number of meds. If you have to go on other meds like antibiotics or you're on other things that for other conditions in life, you're now layering on more meds, more meds, more meds. So these are things to consider when we have people who are HIV negative and questioning, well, it's just a pill a day. And there was an article, this is a 72-year-old woman who's well known in the aging with AIDS community. She's passed away now, but this is a picture of her with her med box basically at 70 some odd years old after I think it was 15, 20 years, maybe a bit more, of being HIV positive. Where she's in this situation now. Now she has other diseases and other chronic stuff to deal with. She had, I think, arthritis and whatnot. But that whole pill a day, it can grow after a while, and you can never stop with the HIV meds, basically. So PrEP research and why we need it. So I wanted to go over specifically the trials for approval, which is, as a researcher, that's what I really think is important. So there are a few trials that you always hear talked about for PrEP approval. The first is IPREX, and I don't know what this stands for. It's Latin or Spanish or something. Spanish, okay. So that's where the acronym IPREX comes from. It wasn't just pulled out of thin air. So they pulled the first letters of some of these and they made it IPREX. It was done in gay and bisexual men and transgender women, so male to female. So there were about 15–20% of the population was actually transgender. It's the only study that currently has transgender people in it. More studies are being done now to include transgender because that's very important that we have that demographic in there. It was done from 2007 to 2009. It had about 2,500 subjects, and this was the first trial done. So they did a placebo arm, like they normally do. They enrolled people who were at risk, which is, again, really important to understand. Sometimes you hear, well, the studies, everybody was given condoms and they all wore condoms. If you wore a condom all the time and you told this study that when you were trying to be enrolled, you were not allowed to be enrolled. You had to be at risk, which meant you said, I don't use condoms all the time. So this demographic, this population, was at risk because they didn't use condoms all the time. They had some level of risky sex, they were enrolled, and then they were randomized. Nobody knew whether they were getting Truvada or a sugar pill. So they did that for 2 years. Everybody had their risk. They were counseled, brought in every 3 months, counseled, given condoms, told to use them. Nobody went into the bedroom and put them on and made sure. And then they asked also about whether they used a condom, and condom use was far from 100%. So the risk was always there. And what they found, again, you'll hear different numbers. If you looked at everybody that was given the pills and you analyzed the difference in HIV rates, it was about a 44% decrease in the group. Let's say this half of the room got Truvada, right, proper Truvada, and this half got the sugar pill. You go home with a bottle, I don't know if you took it or not, and we're going to compare this half of the room with this half of the room. This half of the room had a 44% reduction in HIV rate. Well, when you actually looked and saw and took blood from people and looked whether or not they actually took the drug, because we know compliance, as a pharmacist I can tell you this, and you know this to get people on antiretrovirals to take their meds every day all the time. Compliance is not 100%. So when you actually examine blood samples from this half of the group and you said, okay, some of you didn't take the pill because you don't have the drug in your blood, we're only going to look at the rates of infection in people that actually took the drug. The efficacy was 92%. There was an over 90% decrease in HIV rates if they took the drug every day. No different than condoms. If you have it in your pocket and you don't use it, it's completely worthless. You have to use it. You have to take your blood pressure meds. You have to take your cholesterol meds. It's not a new paradigm. We know that. You have to take your meds. We talk about resistance also. No resistance was seen. This is often a straw man thrown up. Well, what if people don't take the meds? resistance is more of a concern in people that are HIV positive and not taking their meds regularly, because you have to have two things present to get resistance. You have to have the microbe present, and you have to have subtherapeutic levels of something that kills the microbe. So people that are negative, who may or may not have taken their drug all the time, cannot create resistance. And the body doesn't become resistant to Truvada either. You can stay on this indefinitely. So there was no resistance seen. The side effects that were seen most commonly were nausea. There were some GI side effects, and now we understand that there's kind of a startup syndrome where people might have some nausea, they might get headachy, they might lose some weight for the first few weeks, and then it clears. So within a month, most people have no side effects. They then, after the study was done in 2009, they said, okay, everybody in the study, if you want Truvada, we will, it was called IPREX Olay for open label extension. So they said, if you want Truvada, you can get it, and it's going to be the real thing. So out of the 2,500, about 1,600 subjects said, yes, I want to continue. I want to be on Truvada now. So for about 4 years now, they followed people, and they gave everybody real Truvada. Did the same thing, counsel every 3 months, you should use condoms, watch them, looked at the infection rate. Basically, they found that anybody that took it, because they looked at blood levels again, it was as close to 100% effective at preventing HIV as it could be. There were no infections seen in people that took the med every day. And again, they looked at blood levels. So it wasn't just they were given a bottle of pills and told, go home and take this. They were actually testing for the drug in the blood. They found that if you took 7 doses a week, you had about 100% protection against HIV. If you took about 4 doses a week, and again, they measure the blood levels, so blood levels compare to how many doses you take, higher levels for more doses a week. If you took about 4 doses a week, it was still about 100% effective. If you went down to 2 or 3 doses a week, you kind of missed it all week long, maybe took it on the weekend, it was about 84% effective. 84% fewer infections in that group of taking it about 2 or 3 times a week. Good data to understand from our perspective. Certainly the FDA approval and telling clients about this, any provider would say you have to take it every day. And the reason it probably works with about 4 to 7 doses a week is because we're probably, I hate to use the word, but we're probably overdosing most people. You probably don't need as much drug as is already in this pill because it's already manufactured with a certain amount. So it's probably more than is needed, which is why you can take fewer pills a week and still have coverage. So it's important to understand that. And again, in this open label study, they found very few side effects. It was the typical nausea. There might be some diarrhea, vomiting, that type of thing. Very rare. The second major study that was done was called TDF2. It was done in heterosexual men and women. The study was not really done for efficacy. It didn't have enough people to prove efficacy. But they enrolled about 1,200, 19 subjects. And again, they looked at blood levels. And if you look at the blood levels, the proven efficacy, if taken consistently, was about 78, 80%. So 80% reduction in HIV rates in this group. Again, no resistance was seen. The TDF, the Truvada group, had rates of nausea, vomiting, dizziness, and slight bone loss versus the placebo. So you'll hear about a few side effects going forward. One is the nausea. That goes away typically. Kidney effects you'll hear about. Less than 1% of people taking Truvada as PrEP will have any kidney effects, and it's usually very slight. It's a slight increase in blood creatinine, so your kidney function labs become a little bit aberrant. If you stop the drug, 4 out of 5 people can go back on the drug without a problem. So it's a tolerance thing. Your body has to become tolerant to it. For whatever reason, your kidneys have to get tolerant to it. The tenofovir portion of the drugs are cleared through your kidney. So that's where we think it's kidney toxic. So if somebody has predisposed kidney problems, one kidney, they've donated or something, maybe some caution is required. But again, we're not prescribing here. We're advising to go see a physician, and that would be up to the physician to monitor, which is why you go back every 3 months for lab work, is to make sure that if something happens, it's caught. And this kidney side effect is never fulminant. It never has resulted in kidney failure. It's very gradual. It happens over time. So it's not like your kidneys are going to shut down, which again is why you go back to the doctor. Another major study that was done was Partners PrEP. It was done in male and female discordant couples. And the thing about this one was it was done in Africa. And their level of care is, you'll see here, the HIV-positive partner was not on antiretroviral therapy because in the countries it was done in, if you had a CD4 count above 300, you were not treated with antiretrovirals. This is their medical system. So the person who's negative is actually the one who was on PrEP. There was no suppressed here. It was just a positive partner who had a CD4 count above 300 and a negative partner who was on PrEP. This was done in heterosexuals again. There was about 4,700 couples, and they found, if you look at this, there was also just the tenofovir arm. So they used placebo, they used tenofovir alone, and they used Truvada. If you look at the Truvada arm, with blood detection of the drug, you'll see that there was a 90% efficacy. So 90% fewer infections in the group that took Truvada when the positive partner was not on antiretrovirals. So potentially infectious, we're not sure. No difference between adverse events, AEs, between the placebo and any of the treatment groups. So we really did not see a lot of difference here in adverse events. No resistance seen again. So in these studies where we're following thousands of people, we're not seeing major side effects and we're not seeing resistance. So we have data to show that that's not something we need to worry about. The last study that was done in Bangkok. It was with tenofovir only, so not Truvada again. It was done in IV drug users, injection drug users over 5 years, about 2,400 subjects. When they looked at blood levels, it was about 74% effective at reducing HIV. And the thought here is it was only one drug. It was tenofovir. It didn't have the emtricitabine component. It wasn't Truvada as we know it. No resistance seen. Nausea was the most common side effect. So we're seeing the same thing consistently in these different groups. We're seeing it be protective. We're seeing side effects like nausea. We're not seeing resistance. We're not seeing kidney failure. We're not seeing liver problems. And this is, again, in PrEP, in people who are HIV negative. There are 2 ongoing studies now that have had major changes. One is called IPERGAY, and I guess it's French. Again, the acronym comes from the title of the study. This study was Truvada versus placebo in men who have sex with men. So there's an ethical question of whether or not we should even have placebo-controlled trials now, because it seems pretty proven that this works. But the French decided to do that. After 3 years, they stopped the placebo arm in an interim analysis before the study was even done. They only enrolled about 400 subjects out of the 1,900 that they wanted. And they found in an interim analysis that the Truvada group who were getting PrEP was so effective that it was unethical to continue the study. So they actually stopped the placebo arm and are offering everybody PrEP now. This study was also done with intermittent dosing and on-demand. So basically what you'll hear some people say is, well, can I just take it on a weekend when I'm going to go party and a few days after? So they try to look at that here. What they found was the protocol was 2 tablets of Truvada up to 24 hours before you had sex. So let's say you know you're going to hook up Friday night, you're kind of dry season for you, you're not doing a whole lot otherwise. Friday night, you have a big plan. So Friday morning, you take 2 pills of Truvada. You go out Friday, you have your sexual encounter. Maybe Saturday, you have more sex. You take a pill every day that you're having sex, 1 pill after the 2 initial. And you take a pill every day you're having sex until you stop having sex, and then you take 1 pill the day after you have your last sexual encounter. So they found that this was really effective. That's why they stopped the placebo arm. So the question comes up is, well, can I just take this when I have sex and not have to take it all the time? But if you think about this, and when they analyzed this, they found that most people were taking 4 or more doses a week. Because if you have sex Friday and Saturday and Sunday, you have to take a pill Friday, Saturday, Sunday, and Monday. You're taking a pill 4 days a week. We know that that's effective. So the intermittent component might be good for somebody, and what's going to be interesting is the people that had 1 sexual encounter a week or a month or something like that. Was it really effective for them? So that's going to be where the sub-analysis might be interesting. But this isn't overly surprising, because when they looked at the rates of sexual encounters people were having, most people were taking about 4 or 5 pills a week anyhow. But it's important to understand that they stopped the placebo arm because of this study even showed high levels of efficacy. The other study that was stopped is PROUD. It's called, it was in the UK, again the acronym is there. It was done in men who have sex with men. And this was a pilot study. They actually offered men Truvada now or in a year from now to see whether or not people would still want it after a year. What they did was they enrolled, after 545 men were enrolled, they found that they had to open this up again because an interim analysis found that the people who were on Truvada were very protected. The rates of infection were so low that they thought it was unethical to continue the study. So they're now offering PrEP as Truvada to everybody, and this is daily dosing. So again, we have study upon study that's showing that if you take the drug every day, it's highly effective. These studies are still going on, and they'll be reported this year or next year, the actual outcomes. This is a letter, you can't read it, but basically it's a letter to participants enrolled in an ongoing demonstration project that talks about the iProGay study and, hey, you should still take your pill every day. So these studies, the information is out there, but we don't know what the results are. The New York Times in 2010 reported the finding of iPrex that the study finds pill greatly lowers the risk of AIDS. It actually lowers the risk of HIV. They didn't get that headline right, but so be it. This is a summary of the studies. So you can see that in these studies, intent to treat, which is we gave you the pill, we don't know whether you took it or not. You can see the efficacy rates. And if you detect the drug and look at it, you can see that the % decrease in HIV is pretty substantial across those studies. These were the main studies that the FDA used for approval. Why Truvada? Low adverse event profile of all the drugs that are out there for the most part. It's also one pill and it has 2 meds in it. Some of the other combination pills have three or 4 meds in it, and it wasn't thought that we need that many for prevention. It's also very effective at controlling HIV. So adverse events, it's really important to understand this. I want to go over it really quick. There were no serious clinical risks that were identified. The renal problems, you get a slight decrease in renal function, and less than 1% of people that are on this. You can stop the drug and your renal function normalizes. Most people can go back on to Truvada. There's a slight decrease in bone mineral density, so if somebody comes in and they're 70-year-old and they have arthritis or osteoporosis, the doctor may question that, or may want to do a DEXA scan as a baseline and decide whether or not there's a problem further down the road. But there were no bone fractures, there was no bone pain, and it suggested people like that take calcium supplements and vitamin D. There were no liver problems. The liver problems are a class label for most of the antiretrovirals. Steatosis, hepatomegaly, they're seen, we're not sure whether it's the HIV virus, whether it's the meds, all of the drugs in multiple classes of antiretrovirals for HIV have the labeling that they could cause some kind of liver problem. No liver problem was seen in any of the PrEP studies. There's also no increase there's no increased risk for sexual behavior, what we call risk compensation. So people say, well, I'm on PrEP, so I don't have to use condoms anymore. That actually wasn't seen. What was seen actually was a slight decrease in risky sex. People said, well, I take a pill every day and I have it in my palm and I have to think about my health every morning. It's kind of like taking your blood pressure med or your lipid med. What am I eating today? Oh, I'm taking this because I have high cholesterol, so I got to watch what I eat. They also did, in the injection drug user study, they did not find that giving them PrEP increased the risk for injection drugs. They didn't use more drugs. They didn't inject more times during the week. So we're not seeing risk compensation. People are taking the drug and maybe even being more aware of the fact that their sexual health is important. Common adverse events. Adverse events reported more than 2% of Truvada subjects and more frequently than placebo were these listed here. Headache, abdominal pain, decreased weight, what we're now calling the startup syndrome. You got to get used to the meds. It might take a few weeks. Very rarely does this go past the first month of treatment. But it's important that you let people know that. And that's really a physician's job, but you can certainly mention it. So here's a quick list of all the meds from the FDA site that are approved for HIV. You'll see that I put in here, just so you know, lactic acidosis, severe hepatomegaly. This liver problem is on every one of these meds. And it's also on most of the non-nucleosides, the reverse transcriptase, the protease inhibitors. It's a class label. We don't really worry about that, but it's something to monitor. What's in the pipeline? So we have preclinical phase 1, 2, and 3 studies. So this is usually preclinicals in animals, in the lab. Phase 1 is the safety. We'll put in a few human subjects and see if there's any side effects. Phase 2 and 3 are efficacy and safety. There's a lot of stuff coming down the pipeline. We have vaginal gels and anal gels, and we have rings implanted with antiretrovirals. So we're really looking at what else are we doing, which is why it's important to understand the difference between Truvada and PrEP. Because PrEP is still going to apply once these other things get approved. They're actually also looking at a 3-month injection. They're looking at implants, the way women have birth control. They can put a little implant in their arm, and then it's good for 6 months. So there's a lot of stuff coming out. So this is all still PrEP, but it's not Truvada. So it's important we get the dialogue right. We're talking about PrEP and not just the drug. So comparison with contraception versus HIV, you'll see that there's a lot when we have contraception, lots of choices. We're getting there with HIV. These biomedical interventions are very important, and we're growing this slowly, and there should be options, not just one thing we do. More about prior to exposure, the point of exposure, the type of things we can do, and afterwards treatment. So this is just something that we all know already. We still have 50,000 infections a year, but some groups are going up and some groups are going down. This is from the CDC. We see that the youth, aged 13 to 24, we can see that there's an increase in HIV there. There's a slight decrease among black women, but it's leveling out to about 50,000 infections a year. So we need to do something. We need some other intervention here that's really important. Again, this is from the CDC, about 1.2 million people living with HIV, and when you do this cascade, you'll see that they are saying virally suppressed is only about 30% of people that are HIV positive are truly virally suppressed or undetectable. So when somebody's out there who's negative and wants to stay that way, do we depend on people knowing that they're suppressed, or do we give them an option to empower themselves to say, I'd like to stay in this state of health, and I want an option, or another option, or more options to do that? And this is from the White House, the World AIDS Day. This is from Dr. Fauci's slide deck, where he talked about the prevention continuum. There's a treatment continuum and a cascade. They're actually now talking about a prevention continuum. And so in the middle here, you see there's the prevention toolbox, and it's a little blurry because I did a screen capture of it. And then when you blow up that toolbox, you'll see that there's a lot of options here. So we're not just talking about one thing anymore. And PrEP, as well as PEP, which is post-exposure prophylaxis, are real options for preventing HIV now, along with all of these other things. And STIs, STI treatment, microbials, clean syringes, all of these things are very important in HIV prevention. Just so you're aware of it also, the CDC no longer uses the word unprotected. They're using condomless now because protected can come in a lot of different forms. You can be virally suppressed, you can do seroadoption, you can be on PrEP. And the CDC considers all of these protected. So unprotected is something they're moving away from, and they're moving to condomless. And then defining a little bit clearer, what are your risks? Are you having sex with people who are undetectable? Are you on PrEP? Because those are protections. So something for you just to be aware of. Condom use, and this is surprising even to me. This is from the guidelines, the PrEP guidelines, and this is research on condom efficacy. And they state, again, this is CDC stating this, that report when always used in heterosexual couples, so when they ask people, heterosexuals, do you always use a condom? People that said yes versus people that didn't say yes, we always use them. They use them sometimes or never. So you have two groups. Yes, we always use condoms, and no, we don't always use condoms. They followed them, and they found that the HIV rate was only 80% reduced in people that always used condoms. So we want to believe that condoms are the way to go, and they're perfect. They were designed for pregnancy prevention, not necessarily disease prevention. So that is from the CDC guidelines, and I think it's important to understand, would never say to somebody, don't use a condom because PrEP is more effective or they're not truly 100% effective. We definitely want to use them. But it's an important concept that there's data to show this, and if we're quoting numbers for condom use, for efficacy, I'd like to think that there's some reason that we're doing that. And Dr. Dawn Smith actually did a study herself where she looked at men who have sex with men and found that for anal sex, men who always use condom versus men who don't always use condoms, there was a 70% reduction in HIV infection in the group that always used condoms. She also found that over time, 3 or 4 years, most men who have sex with men do not always use condoms. So they go through different stages and different seasons when they might use them. If you ask them, in the past 30 days, have you used a condom? Many people say yes. If you ask them in the past 6 months, have you always used it? They might say, well, not really, because 4 months ago I didn't use it once. So they were considered sometimes users. So this is, again, this is data from studies that were done, the CDC put out there. We often hear, oh, if there was a vaccine against cancer. Well, there is, and this is why cancer research is done. The Gardasil vaccine is out there, it prevents against cervical cancers. There's a new one coming out in February that's going to prevent approximately 90% of cervical cancers. The original one had only 2 types of HPV that it protected against. This new one has 9 types of virus that it protects against. So we have a vaccine for cancer. We have what some people are in PrEP are calling a functional vaccine. If you take it every day, it's believed to be as effective as any vaccine that might come out. You've got to take it every day. And then some things to think about. If we had an HIV vaccine, but it led to decreased condom use, would you question it? So what's more important? Is it condom use or is it HIV prevention? Because they're not the same anymore. There's more than a subtle difference. We want to use condoms, but it's not the only way to prevent HIV now. And again, we're talking about HIV. Do you use seatbelts and airbags? If PrEP came out in 1989, would you question it? A pill that prevents HIV, is this something that anybody would question? Are condoms the only way to prevent this? And is PrEP a functional vaccine? So just things to think about. There are no hard and fast answers, but the type of thing that the people I deal with think about all the time. So how is PrEP taken? There are CDC guidelines, and the link is there. The guidelines are great, and if you want more information, they're thoroughly readable. They're all referenced. They have references all over the place. I would suggest reading them. They're not very difficult to get through, but I think they're really important as a basis to understand why the CDC is recommending this. It's a combination of 2 drugs. You have to take it for at least 7 days before there's enough in your body to protect you, and that's thought for anal sex. For vaginal sex, it's about 21 days because of difference in tissue levels of drug that gets into the tissue. So vaginal protection is about 21 days. You want to be sure about that. And Truvada is the only drug currently approved for PrEP. Although if somebody does have kidney problems, the guidelines suggest that using one of the components rather than Truvada might be an option, but it's not approved for that. I'm not going to go through this. This is just knowing about your risk. There is also what's called a REMS, which is a risk evaluation and mitigation strategy, which goes along with the approval of Truvada. And this is for physicians. It's basically a way for physicians to understand all the implications of prescribing Truvada. There's a medication guide, there's community education, there's provider training, and it's how to implement it. So this was put together, and a lot of people look at this and say, oh, it must be a really harsh drug because the FDA put this together for this. But this is something that goes along with a number of drugs the FDA has put out there. Accutane is another one. You have to make sure the person getting it isn't pregnant. You have to monitor them for liver problems. So just the way the FDA says, physician, know these extra things before you prescribe it. But it's still prescribable by everybody who's a physician. So what are the CDC guidelines? So basically, the CDC says PrEP is recommended, and this is their term, recommended indication for PrEP use by men who have sex with men. If you're an adult man, over 18, if you do not have acute or established HIV, any male partners within the past 6 months. So if you've had sex with a man in the past 6 months, and you're not in a monogamous relationship with somebody who's negative. So if you get somebody with that, who falls into that group, and they have at least one of these following things going on also, the CDC recommends PrEP for them. Any anal sex, receptive or insertive, in the past 6 months without a condom. Any STI in the past 6 months, or ongoing relationship with somebody who's positive. And it doesn't say whether or not they're undetectable. If they're in a relationship with somebody who's positive, it's actually recommended that they be on PrEP. So these are CDC guidelines, important to know. Again, things to think about. When you have somebody that you might be talking to, these are the type of things to think about. Oh, hey, you seem to be somebody that's a good candidate for PrEP. For heterosexually active men and women, it's basically the same thing, but they just throw women in there, or if you've had sex with somebody who's bisexual. And then for IV drug use, they have an indication also, again, HIV negative, any sharing of injection drugs, been on methadone or something else, or the risk of acquisition of HIV. So these are things to think about because PrEP has been found to be efficacious in IV drug users also. So who might be a good fit? Somebody who doesn't use a condom all the time. Somebody's been on PEP, which means they had a risky encounter. New York State actually adds that into people who are good candidates for PrEP, is if you've ever been on PEP, which means you had a risky encounter at some point. Exchange of sex for money, uses illicit drugs, was incarcerated because that's associated with high levels of HIV also. Injection drugs, that type of thing. So access to PrEP. Quick slide to show that biomedical interventions take many years to take hold. So things that we take for granted now, things like mammography, was proven in 1982. And currently in 2000 it was found that there was only 70% adoption of it. So we're talking about things that we know work that aren't necessarily picked up immediately. So there's always a question, well, if PrEP really worked, why isn't it all over the place? It's not a new paradigm. We see this all the time. New biomedical intervention, people push back, we're not sure about it, I'm going to wait for the other guy to do it. Not something new. Cost and coverage. FDA approved Truvada. Insurance companies cover it. It's covered under the ACA plans. If you get somebody who's questioning that, supposedly the best plans are the silver plans because of the copay on a bronze plan. So you're going to pay less out of pocket if you're on a silver plan, but a broker really needs to advise somebody on that. It is on Florida Medicaid. I spoke with DOH and it is on Medicaid. Most insurance companies cover it. ADAP does not because you're HIV negative. There is copay assistance available. So the company, Gilead, that makes it, makes up to $300 a month available if you have insurance that's not state or federally funded, so not Medicaid, not something else. You get a copay card, they cover $300 for you, and it's great. It's $3,600 a year, renews year upon year. All you have to do is call up, give me your Social Security number, or if you don't have one, if you're illegal, or you can still get one, you can still get this copay card. They also, if you don't have insurance, provide the drug free. You just have to submit a bunch of forms and prove that you don't have insurance, and they will give you the drug for free. Does not cover doctor's costs, does not cover lab costs, so that's very important to understand. What does it take? An HIV test, hepatitis, because Truvada actually treats hepatitis B, so if somebody has it, you want to make sure that if they stop Truvada, that they're on something else afterwards. Kidney functions, STI screenings, pregnancy. PrEP is also an option for women that want to get pregnant, women who are HIV negative but have a positive husband or partner. This is an option for them to stay negative during conception because they will not be infected, and then they don't have to stay on PrEP during pregnancy if they're not going to engage in risky sexual activities with somebody who's positive. But if they are, many doctors are now prescribing PrEP for the 9 months, which Truvada is felt to be safe for the fetus for the most part. And then really an open discussion of sex and sexual health. Go back to the doctor or the clinic every 3 months because the prescription is written for 3 months at a time. So people have to go back to their physician or clinic in order to get the next 3 months prescription. They have to be sure that they're HIV negative, their kidneys are working, that type of thing. How do you talk to clients? PrEP is an option. It's not forever. It might be a season. Maybe you just got out of a relationship that you were monogamous in. and now you want to go and you want to actually date and meet people and not worry about this. So you go on PrEP, you see a doctor, you go on PrEP, and when you find another monogamous relationship, you can stop it. You can cycle through this as much as you want. There's no resistance to Truvada. It's not going to stop working. But you do, when you restart it, have to go back to a doctor and be verified that you're HIV negative, that your kidneys are working okay, all that other stuff. It's not a pill a day, it's a program. So you get to see a doctor, you get health care, you go into a clinic, you're actually being monitored. Some people call Truvada or PrEP a gateway to health care, the way some people call marijuana a gateway to other drugs. Don't love the analogy, but it's kind of there. It gets people into care that wouldn't necessarily be there. There is adherence, which is really important. There are a few side effects, and insurance covers it. Really, really quick, 30-second overview of that gets people involved and engaged. Moving forward, I'm not going to go through this. And think about that. There's some information. This is over by the HIV testing area. There's 3 forms that Agardo helped me put together. How to talk to your doctor about PrEP. So this is for patients that they can bring this to their doctor. It has information for the physician on it. It has things that the client or the patient should think about. So that's the first thing that's in this packet. The second is the CDC sheet that has information about PrEP and websites. And the third is about the payer information, if you have insurance, if you don't have insurance. So this is a great thing just to give somebody on going away and saying, here, read about it. It has my card on it also, so they can contact me if they want. But I would suggest think about that. Think about what are you going to tell somebody. Don't wait when it happens. Think about my 30-second elevator pitch about PrEP. The same thing you'd probably do about condoms or anything else. How to avoid getting caught with how do I talk about this. And there's also, just so you know, every 4th Saturday, what I'm calling a workshop. It's kind of my office hours. I'll be in room 200 upstairs at 12:30 every 4th Saturday. So this flyer is actually in the testing area. It's on the website, pridecenterflorida.org/prep. So you can tell people they can come, they can talk to me, they can call me, they can email me. But here, at this, I'm available here in person. So if people want to come and talk to me, that's fine. And that's all I have.